perspective. I'm not quite sure if you still see the screen. Hello? 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 Dr. Shadi? Dr. Shadi?
Yes, yes, okay.
Yes, do you still hear me? Yeah, because
yes.
there was no response. Yeah, all right.
Administrator, mute for all participants.
For all participants until we finish. Okay, that's nice. Yeah, so I'm gonna start my talk today about adenomyosis. This is a very important topic in gynecology. We're gonna discuss it from the ultrasound point of view. Dr. Shadi, there is a problem with the screen share. If I have someone from the technical team.
Yes, no problem. You can press on the bottom of.
Yeah. Okay. Okay. Now it's working. Okay. So this is just a brief about disclosure. I have nothing to disclose. I didn't receive any financial support for this talk. And my objectives for this talk would be that someone is putting a line. It's okay. So the objective would be to talk about the prevalence and discuss the pathophysiology and the clinical presentation of adenomyosis. Our topic today would be about the role of transvaginal ultrasound in the diagnosis of adenomyosis. I'm going to show you a gallery of pictures and cine clips. And what will not be discussed in this lecture is the role of MRI in the adenomyosis, the medical and the surgical management of adenomyosis. So I would start my topic talking about the prevalence because when I did the literature search, there was some quite changes about the prevalence of the adenomyosis. The reported prevalence varies widely from about 5 to 70%, depending on the method used for the diagnosis, with a mean prevalence of 20 to 30%. So previously, the diagnosis required a histological analysis, and it was dependent on the hysterectomy specimens. The disease was thought to occur primarily in women in their 40s and 50s. Currently, the definitive diagnosis is more commonly made from the results of the hysteroscopic and laparoscopic biopsy. We know that the advances in the minimally invasive surgery have helped us quite a bit. And adenomyosis has been frequently diagnosed in women in their 20s and 30s, with some cases discovered during adolescence. We never have seen before the adenomyosis in adolescents, but there are reported cases right now. So a prospective study was done in 2015 that found that about 30% prevalence in non-leprous women aged 18 to 30 years who presented for counseling for contraception. So sometimes it's an incidental finding. It's not the presentation, I mean. And it's also found on imaging and hysterectomy specimens in postmenopausal women, as I mentioned. Furthermore, recent histologic-based data may be unreliable as laparoscopic surgery results in a morcellated specimen that modifies the spatial arrangement of the tissue and can lead to more difficult diagnoses. So take care when you do laparoscopy and obtain a biopsy from this finding. So to define the adenomyosis, there is no agreement on the definition. Actually, if you search the literature, you wouldn't find a definitive definition for adenomyosis. Why? Because the classification of the adenomyotic lesions. Someone is playing, so could you please stop that?
Abdurrahman.
Yeah, if you could disable the participant side because someone is playing. Okay, so there's no agreement on definition, as I mentioned, and that's because the classification of the adenomyotic lesions on the histopathology and from the imaging point of view is difficult, you know, and it remains unclear. Adenomyosis is a common non-malignant uterine condition of its ectopic endometrial tissue, glands, and stroma in the myometrium. Sometimes it's considered a spectrum of the adenomyosis, of the endometriosis, as we know. So adenomyosis induces hyperplasia and hypertrophy of the myometrium, thus enlarging the uterus. That's why we know from the clinical findings that you find the uterus of the adenomyotic women is enlarged. We know that in 2011, the FIGO, the Federation International of Gynecologists and Obstetricians, was trying to put a nomenclature, and they already did. So they did the palm coin and they classified the different causes of the bleeding, abnormal uterine bleeding. They classified into structural causes and non-structural causes. The structural causes, they put it in the word PON, which stands for polyp, adenomyosis, leiomyoma, and the malignancy as the structural causes of the bleeding, where the COIN stands for the coagulation defects, the ovulatory dysfunction, the endometrial factors, the iatrogenic causes, and not otherwise specified for the N. So still, we do need a uniform and shared reporting system to be implemented in order to improve our understanding of the imaging factors. I would give you a little bit about the pathogenesis of endometriosis, of adenomyosis, I'm sorry, because this is important to understand the different aspects of the diagnosis. So we know that adenomyosis still remains elusive. It's not a single theory can explain the different phenotypes of the disease. And furthermore, adenomyosis often coexists with other gynecological conditions, such as endometriosis and uterine fibroids, and this increases the heterogeneity of the available data. The pathogenic mechanisms involved in the adenomyosis need to be fully elucidated, but in the last decade, over the last 10 years, there was an increasing number of the studies that have shown that 6 steroid hormone receptors, such as inflammatory molecules, extracellular matrix enzymes, growth factors, and neuroangiogenic factors play a major role. So in Fertility Sterility 2018, there was a paper about the pathogenesis of uterine adenomyosis. Is it an invagination or a metaplasia? And I would discuss the two theories in order for you to get this update. So according to the most common theory, adenomyosis results from the invagination of the basalis layer, which is the basal endometrium, into the myometrium through an altered or interrupted junctional zone, which represents a highly specialized hormone-responsive structure located in the inner third of the myometrium. So please, you make sure of this note that the junctional zone, it's in the inner third of the myometrium. This is quite important because we will depend on this for the ultrasound for the invasion. The molecular alterations in the eotopic endometrium seem to contribute to the migration and the survival of the ectopic endometrial implants beyond the myometrial interface. Even though the alterations in apoptosis, which we know that apoptosis is a programmed cell death, the steroid hormone responsiveness, the extracellular matrix pathways, all have been found in both the adenomyotic lesions and the eotopic endometrium. So this is the underlying mechanism, needs more evaluation. In addition, we have a terminology called the TIAR. This is the rule of tissue injury and repair. It's proposed to be the primary mechanism for the myometrial invasion. It was hypothesized that chronic peristaltic myometrial contractions may induce continuous microtrauma to the junctional zone.
Dr. Heba, please slow down. Dr. Heba, please slow down.
Sorry?
Please
slow down?
Yes.
Okay. I'm so sorry. I'm a bit in a hurry. Okay.
I understand. We have 1 hour.
Okay. Okay. No worries. Yeah. I would just talk about the chronic peristaltic myometrial contractions here. They thought previously that it was the endometrium and the myometrium, but nowadays they thought that there is a movement inside the myometrium called the peristaltic contractions. This induces a mechanism, continuous microtrauma to the junctional zone. And we understand now from the different pathologies of different diseases that microtrauma is the key to most of the pathologies of most of the diseases. So it plays a key role here because it causes inflammation. It in turn promotes the local increased estrogen production. So it induces a vicious circle. That's why adenomyosis is a difficult diagnosis because of this pathophysiology. A positive feedback mechanism is generated and the chronic hyperperistalsis in the junctional zone promotes repeated cycles of auto-traumatization. So the trauma is not like a constant event. The trauma happens and rehappens and happens again and again and again. So that's the point. So the TIAR, which is the tissue injury and repair theory, it stresses the importance of tissue damage to the endometrial myometrial interface, supports the common understanding that adenomyosis is associated with multiparity. This explains why adenomyosis is common in multiparous women with previous cesarean section or previous uterine surgery. So this was the theory that explains all of these risk factors and its relationship to the adenomyosis. So the other theory that I told you clonogenicity of the human endometrial, epithelial, and stromal cells. We all hear about the stem cells, and stem cells play a major role in our bodies nowadays, and especially in the medical and clinical research. So this study was about an alternative pathogenic theory for the adenomyosis. What this study is talking about, it talks about the proposal that adenomyosis arises de novo from a metaplasia or of the embryonic or the adult stem cell in the myometrium. So they say that there are inside the myometrium, there are adult stem cells or embryonic crests. And what will happen in the adult life that this embryonic crests would undergo metaplasia. And we know that the metaplasia is a change of the type of the epithelium from one type to the another for the adaptation. So what happens that intramyometrial embryonic pluripotent Mullerian remnants may undergo metaplastic changes in the adult uterine wall. What will this lead to? It will lead to the development of de novo ectopic endometrial tissue within the myometrial wall as the adenomyotic foci. So this explains, if you could see here, this is an adenomyotic focus explained by this theory. However, this hypothesis of the adult endometrial and stromal stem cell differentiation, they are deposited in the myometrium after retrograde menstruation. If you remember this retrograde menstruation theory in the endometriosis as well, it remains for decades talking about this. They are still mentioning that this might be explained also in adenomyosis. So Chapron et al. Described that adenomyosis from outside to the inside envision, because we know that in adenomyosis what happens that the endometrial lining goes through the myometrium from inside outside. But what will explain the outside to the inside invasion is this hypothesis by Chapron et al. He hypothesized that the migration of the ectopic endometrial cells from the posterior endometriosis nodules into the myometrium. And this theory was supported by the high prevalence of the posterior focal adenomyosis of the outer myometrium, what we call the foam. You would hear this terminology, foam. Foam stands for focal adenomyosis of the outer myometrium. This was found in patients with deep infiltrating endometriosis in the posterior compartment when it was diagnosed by MRI. So now we understand about two theories play a very important role in the pathogenesis of adenomyosis. They weren't available before, so they are new, and they are talking about how the adenomyosis develops. So just to give you a basic concept about the basal epithelium, so the human endometrium regenerates from the lower basalis layer. We all know that. We learn about that in medical school. So it's a germinal compartment that persists after menstruation to give rise to the new upper functional layer. Because we know that the adult stem cells are present in the tissues that undergo regeneration, it's hypothesized that the human endometrium contains a small proportion of the epithelial and stromal stem cells that's responsible for the cyclical regeneration of the endometrial glands and stroma, that these cells would exhibit clonogenicity. It means that it's a stem cell property. We know that the cells in our body would differentiate according to the type of the organ, but we do have a totipotent or pluripotent cell that could differentiate into other organs. If you put it, endometrial cells, you put it in the myometrium to differentiate as endometrial glands and stroma inside the myometrium, which explains the theory of the adenomyosis. This picture from the city of Toronto, I just thought to put it here for you. So by the end of the pathogenesis of the adenomyosis, I want to tell you that it's still unclear. The pathogenesis of the condition is still unclear. It cannot be understood by the currently available theories, and there is no unique theory for the adenomyosis, and it's still heterogeneous, it's still not yet clearly defined, and this would put us that adenomyosis is still a very hot topic in the research. So if we go for, now we understand the pathogenesis of the adenomyosis and how the adenomyosis develops. So we will go to talk about the risk factors. So we do have in the early literature that it was based on the results of the analysis of the surgical specimens. Why this is important? Because in the past, we used to do hysterectomy. Then we take the specimen, send it for histopathology, and then we know that the patient has adenomyosis. Without sending the specimen to the histopathology, we weren't able to diagnose that the case having adenomyosis. But nowadays, we do have advances in minimal invasive surgery, as I mentioned, advances in hysteroscopy and laparoscopy. So we are able to take samples, specimens, and send them for histopathology. And we know this even without removing the entire uterus. So the proposed risk is related to multipolarity. It can be either during pregnancy-related endometrial invasion of the myometrial during the trophoblastic implantation. So that's why they say that if the woman got pregnant, so there might be a trauma for the endometrial myometrial interface, and there would be endometrial invasion inside the myometrium. That's why it was related to the multiparity, or explains the multiparity in a sense. So the clinical presentation, as I mentioned, the signs and symptoms include the pain, the menorrhagia. We want to refrain from using the terms like menorrhagia, metrorrhagia. So menorrhagia is heavy menstrual bleeding, metrorrhagia is the irregular bleeding, dysmenorrhea is the painful periods, and dyspareunia is the painful sex. So however, because of the widespread use of the pelvic ultrasound, it's now estimated that up to a third of women with adenomyosis are asymptomatic. So this is a kind of a problem, because the woman will come in, have no complaint. She came to insert an IUD or just for any other presentation. She's asymptomatic, and you do an ultrasound and you discover that she has an adenomyosis, and now here you go. You need to counsel the woman about this diagnosis. So we know that the heavy menstrual bleeding is the most common symptom if they are symptomatic. So we mentioned that 1/3 are asymptomatic, totally without symptoms. The other 2/3 will present with bleeding, like heavy menstrual bleed. And this would be caused by the increased total volume of the endometrial glands in the uterus. It will be caused by the increased myometrial vascularity from the ectopic glands, because it's not normal to have endometrial glands inside the myometrium. It's likely that the extent and the depth of the myometrial invasion is directly related to the degree of the bleeding. That's also important, because if the woman is coming to you with excessive heavy bleeding, you would understand that the extent and the depth of the adenomyosis is quite heavy. The dysmenorrhea is another kind of pain. That's painful menstruation. It's the second most common presentation of adenomyosis. And the reason behind that is the intramyometrial bleeding of the displaced endometrial glands, because every month this endometrial tissue is bleeding every month under the influence of hormones. So it's not different when it's inside the myometrium. It will bleed as well. When it bleeds, it will cause increased levels of prostaglandins, and this will cause pain in the form of dysmenorrhea. The prostaglandins as well, they act as vasoconstrictors, as we all know, because uterine contractions, both of which will contribute to the dysmenorrhea. So I hope that by telling you this, now you understand the pathophysiology of the adenomyosis, then how the woman will present to you, either in a third of cases asymptomatic without a symptom. You will discover that incidentally on ultrasound, or she will come with pain or bleeding. So what will you find at physical? Not too much, right? They often have pelvic tenderness, sometimes with diffuse enlargement of the uterus. They do have pelvic tenderness. However, these symptoms and all the physical examination findings, unfortunately, are non-specific. They could occur in most common disorders. They could occur even with conditions that are commonly associated with adenomyosis, like the fibroids, the endometriosis, and the combined with adenomyosis, or even without adenomyosis. So if you do a physical examination for the woman, it's not quite helpful in cases of adenomyosis. What about adenomyosis and fertility? Does it affect fertility at all? This is a question. So adenomyosis is thought to play a role in infertility. It should be considered in women undergoing fertility workup. And we have reports that show association between the increasing thickened junctional zone and the decreasing implantation rates during in vitro fertilization. So even if the woman got pregnant through an IVF, there is a risk for first trimester miscarriage rates are higher in women with adenomyosis. There are proposed mechanisms of that, such like disturbed uterine peristalsis, as I mentioned, the altered sperm transport, a toxic effect of increased endometrial inflammation on the embryos, and altered hormonal environment in the uterus. The endometrial receptivity, the endometrial as an environment for the fetus is not quite healthy, in cases of adenomyosis. That's why even if the woman is suffering infertility, even when they got pregnant, they still have problems with these pregnancies. So now I'm gonna shift to the role of imaging in the adenomyosis, which is the most important part of our session today. Forgive me for the basic concepts that I introduced at the beginning of the lecture, because I thought this is very important for you to understand what's the condition of adenomyosis before going and talking specifically about ultrasound. So the development of imaging techniques such as MRI and transvaginal ultrasonography has allowed clinicians to make a non-invasive diagnosis of adenomyosis in women undergoing conservative treatments and identifying different phenotypes of the disease. What I mean by that, that before in the past, we depend heavily on the MRI to diagnose adenomyosis. We depend heavily on the more and the most invasive way is to remove the uterus of a woman, even if she wasn't nullly gravida, even she's only 40 or something. In order to take the specimen, send it to the histopathology, as I mentioned, and diagnose the case. But right now, we have a lot of advances. Even the transvaginal ultrasound replaced the MRI in this aspect. So after some attempts of histological classification, Kishi et al. In 2012, they classified the adenomyosis in 4 subtypes according to the MRI. They depend on the lesion of the location, either to the inner or to the outer myometrial. So we do have the intrinsic, extrinsic, intramural, or indeterminate when we don't know where it is. So we cannot say, is it intrinsic, extrinsic, or intramural? We would define it as indeterminate. In 2014, Gramabizis et al. Proposed a clinical histological classification system they identified as diffuse, focal, and cystic adenomyosis. And more recently, Bezot and Dry proposed 3 subtypes like internal, external adenomyosis, and adenomyomas, according to the MRI features as well. So this is a classification based on the MRI. I'm gonna show you other classifications based on the ultrasound as well. So let's start by talking about the transvaginal ultrasound. Why the transvaginal ultrasound is important in adenomyosis? Because it represents the first-line imaging technique to diagnose adenomyosis. Why? Because it's widely available. Everyone has an ultrasound machine, right? Relatively inexpensive. Nowadays, the equipments are much cheaper than before, and it's very accurate only if performed by expert sonographers. That's why the workshops and the training sessions on all of this training is very important to acquire the necessary skills to diagnose. So what's the sensitivity to detect adenomyosis? It ranges between 65 to 81%. Not too bad, right? For a non-invasive technique. And the specificity ranges from 65 to 100%. That's why we like ultrasound. We depend heavily on ultrasound in the diagnosis of most adenomyosis cases nowadays. So there was a recent meta-analysis. It was done from pooling results from 80 studies. This meta-analysis discovered that the 2-dimensional transvaginal ultrasound has a sensitivity and a specificity of about 83 and 63% respectively. When they do the sensitivity and specificity for the 3D ultrasound, 3D transvaginal ultrasound, they find the sensitivity and specificity that ranges between about 80 and 88.9, which is about 89 and 56%. So it's not too different, the 3D from the 2D, but I will show you by the end of this session how the 3D plays a very important role in some of the equivocal cases, but still there is a big role for the 2D ultrasound, just to put in mind. So there was a uniform standardized reporting system of the ultrasound findings of adenomyosis. It was developed by the Morphological Uterus Sonographic Assessment, what we call it MUSA criteria. I believe one of my colleagues have talked about the MUSA criteria very well for you. So according to those criteria, the typical ultrasound features to consider in order to make a diagnosis of adenomyosis were described as follows. You should see an asymmetrical thickening of the uterine walls. That's important to see. You would see an intramyometrial inside the myometrium cysts or hyperechoic islands, or both. You could see cysts, you could see hyperechoic islands, you could see both. There would be fan-shaped shadowing of the myometrium. There would be myometrial echogenic subendometrial lines and buds. There would be translesional vascularity, and I'm gonna talk in details about the vascularity in a minute. So there was also some work from Van den Bosch and Bruijn and his et al. That describes the disease according to the location. They classify the adenomyosis into anterior, posterior, left lateral, right lateral, and fundal. This classified the lesions to be focal or diffuse. Then they describe the presence or the absence of the intralesional cysts. Then they talk about the myometrial layer involvement. So they comment about the junctional zone, the myometrium, and the serosal involvement. Then they come to the disease extent and they have to give a comment about, is it less than 25%, between 25 and 50%, or more than 50% of the uterine volume affected by the adenomyosis and the lesion size. The system would help to standardize the ultrasound description of adenomyosis. However, it has some limitations. We cannot fully implement it in clinical practice because of the following reasons. First off, the measurement of the uterine volume affected by the disease is difficult to objectively evaluate. The system needs to be validated to be correlated with the clinical findings and the fertility outcomes in further studies. In fact, another major problem is the definition of the severity of the disease and the identification of these features that make clinically more severe adenomyosis. It's not about finding an adenomyosis. We mentioned that in 1/3 of cases, the presentation of those patients will be asymptomatic, without symptoms. How are we going to assess the severity of the disease is a very important clinical question. And the correlation of the adenomyotic finding and the bad outcomes for the patient is very important during the counseling process. So there was a study, it's an observational study that was published in Ultrasound Obstetric Gynecology. It's about the association between ultrasound features of the adenomyosis and the severity of the menstrual pain. Could we, when we look at the uterus of a woman with adenomyosis, tell how severe is her pains? Or if the woman is having a severe pain, could we tell that the ultrasound picture would show this and this and that? So that's another important question. And here we find that Naftalin and his colleagues, they showed a positive correlation between the number of the ultrasound features of adenomyosis and the severity of the menstrual pain. But there is no available evidence in which features are relevant from a clinical perspective. That's a problem. Sometimes we do have a gap between the clinical research and the practice. Here we didn't find an application in the practice, but we did find an association for the research. Talam et al., they developed a clinical prediction model to identify the disease by using the most relevant features. However, those models need to be externally validated, and more evidence should support their reliability. So again and again, the adenomyosis is a disease that have a lot of challenges during the pathogenesis of the disease, the clinical presentation, and even during the management. So here, I'm going to start with the ultrasonographic description of this disease. Given the numerous description of adenomyosis on ultrasound, it's useful to organize the findings into 3 groups. If you want to remember one slide, remember this. It's a disease, adenomyosis. And adeno means ectopic endometrial glands. So what are you going to search for is ectopic endometrial glands outside its normal position, so outside the endometrium, would be in the myometrium. And a meiosis means muscular hyperplasia and or hypertrophy, increase in the number and increase in the cell volume, and increased vascularity. So the bottom line here for ultrasound, when you look at the uterus, you want to have a scan, you want to comment on is there any ectopic endometrial glands inside the myometrium? Is this uterus bulky, muscular, there is hyperplasia and hypertrophy? And what about the vascularity? When you put the color Doppler mode, what's the picture? Is this normal vascularity? Is it increased? I'm gonna go in details through every aspect of these features. So again, this is a very important slide describing that the adenomyosis is an adenomyosis and myometrial vascularity. Adeno means ectopic endometrial glands and stroma. That's fine. That's a book definition. But how can I see an ectopic endometrial glands and stroma on the ultrasound? This is how you see. You are looking for echogenic striations and nodules. I'm going to show you examples of that. You are looking for myometrial cysts and cystic striation. So this is how you see the ectopic endometrial gland inside the myometrium. These are the features you are looking for on the ultrasound. How am I going to see the meiosis, which is the muscular hyperplasia and hypertrophy? How am I going to tell that this is too much muscle in the myometrium? On the ultrasound, you're gonna see the thickened inner myometrium, because I told you, you are looking for the junctional zone. Junction zone is in the inner third of the myometrium. You are going to see myometrial thickening, focal and diffuse. You're going to see enlarged globular uterus clinically and by ultrasound here. And this is very important, the blind shadowing, what you call it, the Venetian blind shadowing. I got a slide to explain this to you. This is, we call it pencil thin, because it's like a pencil, just a very thin shadow. Then you put the color Doppler on, you look at the myometrial vascularity. You are going to see increased vascularity and penetrative vessels, tortuous penetrating vessels. This is the key. All of these aspects will give you myometrial heterogeneity, what we call cirrhosis of the uterus. And I have another picture at the end of the slide showing you the cirrhosis of the uterus, how it looks like. This is the picture of adenomyosis. If you find adeno, the meiosis, and the myometrial vascularity, this is how you diagnose adenomyosis on the ultrasound. So I'm gonna start with the first aspect. We mentioned it's ectopic endometrial glands inside the myometrium. So we are going to see this on ultrasound. This is the picture. It gives you a very clear identification of the uterus with those arrows pointing at the echogenic striations we are talking about. So there is an endometrium and there is a myometrium, and there is an endometrial myometrial interface. If you see striations between the endometrium and the myometrium, this means that there is a continuation between the endometrium and myometrium. This is a striation. So this is a sagittal grayscale view in a 51-year-old postmenopausal woman. It shows echogenic striations. These are the arrow heads. It shows also that there is thickening of the endometrium. This is what's seen up here, that there's thickening of the endometrium. This is a very nice sagittal view also from transvaginal ultrasound. It shows you the echogenic nodules. This is an hyperechoic nodule. So if you see this, this is not a calcification. It looks like a calcification, but it's not. It's an endometriotic spots. It's echogenic nodules. If you see this hypoechoic with the big arrow, the black arrow, this is a cyst. This is what we call myometrial cyst. And this is a very important feature of the adenomyosis, provided that this patient is not pregnant. And don't tell me that adenomyosis happens in women in their 40s and 50s. I told you earlier, we see this adenomyosis now between ages 20s and 30s, and we even have reported cases in adolescents. So you need to do an pregnancy test if the woman is amenorrheic. But this myometrial cyst is very, very important. The study by Bezos et al., they found that myometrial cysts to be the most sensitive and the specific ultrasound criteria, this one. If you see it in adenomyosis, it's very sensitive, it's very specific. How you describe it, it's typically between 1 and 5 millimeter. If you put a measurement here and you measure it, it's between 1 and 5 millimeter, and it's most commonly anechoic. That's why it's a cyst. However, because the cyst contains active endometrial tissue, sometimes they could contain echogenic material. This will represent blood. So if you find something whitish inside, this is blood. And visualization of these cysts can be improved by decreasing the field of view and zooming in on the image. If you want to better visualize the cyst, if you can't see it very well, reduce the field of the view on the ultrasound machine and zoom in on the image so you could see it clearly. Then occasionally an entire striation can fill with fluid, something called lollipop. Sometimes this cyst will elongate. I will show you a picture for that. This is a lollipop. We all know this, right? So this is the sign of the lollipop. Tell me how gynecologists have an imagination. So they describe this as a lollipop sign, which indicates a myometrial cystic striation that's in the between connecting the anterior myometrium to the endometrium. So it's extending from the endometrium to the anterior myometrium, and it looks like a lollipop. That's why they call it a lollipop sign or a lollipop diverticulum. The second feature on ultrasound is the muscular hyperplasia and the muscular hypertrophy. You want to tell me that the muscles of the uterus is more than enough. It's increased in the number, increased in the volume, increased in the size. How are you going to tell me that on ultrasound? I'm going to talk to you about how the ectopic endometrial glands remain hormonally sensitive. So this ectopic endometrial glands, it's not in its proper place. It moved from the endometrium to the myometrium, but still it obeys the hormones. So it's under the influence of the hormone, and it can incite a local reaction within the surrounding myometrium. This will result in myometrial hyperplasia and hypertrophy. So the myometrial thickening, it can be focal in one part, or it could be throughout the myometrium, which is, we call it diffuse. So although focal areas have relatively indistinct borders compared with those of the leiomyomas, and I have one complete slide to explain to you the difference between the fibroid or the leiomyoma and the adenomyosis. It depends on the extent of the process that the uterus may remain normal in size, demonstrate asymmetric myometrial thickening, or even develop the diffuse globular enlargement of the adenomyosis. So if we find an asymmetric adenomyosis, this most frequently involves the fundal region. That's very important because some of my colleagues will see other parts of the uterus first. No, first of all, you need to comment on the asymmetric adenomyosis in the fundus, less frequently in the anterior wall, and rarely on the cornea near the cervical os. These are the rare sites. So while the classic finding of the junctional zone thickening at MRI can be appreciated at ultrasound, the precise measurement of the junctional zone are more difficult to obtain and are less helpful at ultrasound. That's why I'm going to show you how to avoid this during the 2D and use other modalities such as the color Doppler and the 3D ultrasound to help you in the diagnosis of adenomyosis. So this is another ultrasound picture. It depicts it's a sagittal transvaginal ultrasound image. You could see how the uterus is diffusely bulk. There is a heterogeneity of the myometrium. You could tell that this myometrium is not homogeneous. This part is not equal to this part. There is a thickening of the myometrium. This is how you see the adenomyotic uterus. Again, here, you see these shadows? These shadows are very important also in the diagnosis. We call it pencil thin because it's like when you draw with a pencil. It's a pencil thin shadows in the myometrium. This is very important during the diagnosis of adenomyosis as well. So I'm going to talk about the focal adenomyosis. This is a picture of a focal adenomyosis. If you could see here how it's very well delineated in a 46-year-old woman. This is sagittal gray scale, and it's also there is a round mass-like adenomyoma. There is no capsule here. That's an adenomyoma. It's not a fibroid. I'm going to show you another picture for the fibroid, but this is in the background also of diffuse adenomyosis. This is another MRI T2 weighted image. It demonstrates also the adenomyoma in a background of diffuse adenomyosis. So this is the same patient. We did the transvaginal ultrasound first, then we followed up with the MRI to give you the comparison between both with different modalities of the radiology. What we call the cirrhosis of the uterus, they describe these thin shadows as this, the Venetian blind appearance. When you see Venetian blind, you would feel that Venetian is a very strange word to you. For whom those English is not the first language. Venetian comes from Venice in Italy. They used to use these shutter windows. So it gives the same appearance. That's why they describe it as Venetian blind appearance. Someone is playing a game. I'm sorry. Dr. Shadi?
Yes, with you.
Yes, please. Someone is playing with the pencil or the pen.
Abdurrahman. Okay, I will
Yeah.
manage.
Thank you. So the heterogeneity of the combination of this heterogeneity with the thin shadows, when you see these thin shadows like the window as I explained it to you, with the small hyperechoic nodules and the striations. All of these are suggestive signs of the ultrasound appearance for the end-stage liver disease. It looks like an end-stage liver. That's why they call it, it looks like cirrhosis of the liver. We're gonna call it cirrhosis of the uterus. So if you hear this term, it's important to understand why they call it cirrhosis of the uterus, because it resembles the picture of the cirrhotic liver with all the criteria I told you about, but this is an indicative of the adenomyosis on ultrasound. The third important criterion was the vascularity. You need to comment about the vascularity when you put the color Doppler mode. In the setting of adenomyosis, you're gonna find that there is an increased myometrial vascularity, and this increase in the vascularity is owing to the muscular hyperplasia and hypertrophy. We all know that when there is a muscle, the muscle would have blood supply. So when there is an increase in the muscle mass, number, and volume, there would be an increase in the blood supply. And this would be helpful in the clinical practice because we could put the color Doppler and we could comment on the vascularity. So there would be an increased areas of vascularity that reflects the distribution of the adenomyosis. It may help to determine whether the leiomyoma are also present, because we know that there are challenges between in the combination of the adenomyosis with sometimes with fibroids or a leiomyoma. And it's very important to differentiate from the pattern of the vascularity between the leiomyoma and the adenomyosis, and to comment if this adenomyosis is associated with leiomyoma or not. So the color Doppler ultrasound would reveal the increased number of tortuous vessels, as I showed you earlier, and I'm going to show you again, that penetrate through the involved myometrium, an appearance that also seen at angiography. So this type of vascularity is distinctly different from the pattern typically seen with the leiomyomas, where we are going to see the vascularity in leiomyoma is coming from outside circumferentially around the myoma. So this is a sagittal grayscale. If you could see here, this is the 2D picture without putting the color Doppler. You could still see some heterogeneity in the myometrium with cystic lesions and nodules in the posterior myometrium. If you put the color Doppler like this, we're gonna see the increased vascularity, and we could see here, and there are these characteristic tortuous vessels. So these characteristic tortuous vessels penetrating through the myometrium is diagnostic for adenomyosis. So this is another sagittal grayscale view, transvaginal ultrasound of the uterus in a different patient. It shows also all of this discrete mass. It's very heterogeneous lesion. It's typical for leiomyoma. So now you see the difference. This typical leiomyoma could draw with a pencil around it. It's separated from the endometrium. This is a myoma. It's not an adenomyosis. If you go back, this is adenomyotic foci. This is with the color Doppler, and this is a leiomyoma or a fibroid. So here, if you put a color Doppler on the same previous patient, you would find the blood vessels are not inside the lesion as in adenomyosis. It's circumferential all around the myoma. That's why it's a myoma. The myoma, it has a capsule, and this capsule, the blood vessels, when the blood supply comes, it comes from the outer border, giving us a clear distinction between the leiomyoma and the adenomyosis. This would be very helpful when you differentiate between an adenomyosis and a leiomyoma, or a focal adenomyoma and a leiomyoma. So let's talk about some technical pearls here. The best way to visualize is the shadowing, because I told you that the shadows are very important in the diagnosis of adenomyosis, and the heterogeneity of the myometrium is also a very important. You need to use a high frequency transvaginal ultrasound. We know that the high frequency transvaginal ultrasound will give us a better picture. However, it has another drawback. What's the drawback? Sometimes it's difficult to adequately penetrate through the entire posterior myometrium at the high frequency. So what should we do? When we put the transvaginal ultrasound, we could see, but we cannot go further. The penetration would be much less. So it's helpful to do low penetration mode, or to use the lower frequency transabdominal ultrasound probes. So if you couldn't see the extent of the lesion, you use the transabdominal, or you combine transabdominal with the transvaginal to better visualize the lesion. So here, again, this is a 2D ultrasound with the abdominal probe. You could see that there is something wrong with the uterus. This is not a normally appearing uterus. We cannot Something with the share screen?
Try again to share screen. Are there any problem?
Okay. Is it clear now?
Yes, yes.
Yes. Okay. So this is an abdominal 2D ultrasound picture. It shows us a diffuse myometrial heterogeneity, which is better visualized when we use the transvaginal ultrasound. I put these two pictures to give you, this is the same picture you are seeing with the transabdominal probe. This is when we did the transvaginal probe, you could see much better. You could clearly visualize the myometrial cysts, the shadowing we talked about, the heterogeneity of the myometrium, and the diffuse enlargement in the posterior myometrium. That's why it's very important to evaluate the patient with the transvaginal ultrasound, and sometimes we need to use the transabdominal, as I mentioned. So this is the shadows of the shutter window, as I mentioned. With the penetration mode, we show improved visualization of the stromal muscular heterogeneity with the pencil thin, as if you wrote it with a pencil. It's the pencil thin shadowing, the echogenic nodules, the myometrial cysts, I told you, very important, and the obscuration of the endometrium. You cannot sometimes tell where is the interface between the endometrium and the myometrium. So take home message for this part, that it's better to use Senny clips through the uterus to better appreciate the ultrasound findings of the adenomyosis. So for my colleagues all over the world, I'm telling you, if you want a consultation on an ultrasound image about adenomyosis or any other topic, you want to send it to another colleague, send the Senny clip. Don't send just a photo or a picture of what you're seeing, because I'm gonna show you some video clips demonstrating how clearer is it when we use the Senny clips. The other thing, that the myometrial heterogeneity and the Venetian line shadows, as we mentioned, they often become more apparent when we scroll through the uterus. So you need to scan the uterus everywhere, not just only one view and you comment about it. When you use the Senny clips, it's also easier to demonstrate the continuity of the echogenic striations with the endometrial myometrial interface, which is key to diagnose adenomyosis. So this is a picture of, this is just only a single screenshot from the picture for an adenomyotic. It shows diffuse thickening of the endometrium, which is very heterogeneous. This is the clip. When we do the Senny clip, you're gonna see it much clearer. I'm gonna open it now for you, so you could see when we scan all across with all the shadows, it appears with the endometrium and the myometrium. So again, I'm gonna repeat the Senny clip for you to demonstrate how many pieces of information we got from the Senny clip rather from one image. So another modality that we could make use of is the 3D ultrasound. We could do coronal reconstruction of the uterus. It's very useful adjunct to the conventional imaging in the sagittal and transverse planes. When I say an adjunct, it means that we need to do the 2D ultrasound, but we could add more information by doing the coronal 2D or 3D ultrasound. It's not replacing the 2D, it's beside the 2D. Viewing the coronal plane through the endometrium in either 2D or 3D reconstructed images would allow for complete visualization of the fundal endometrial myometrial interface, because this is the most common location for the focal adenomyosis, and it's difficult sometimes to visualize in the 2D images. That's why this is the beauty of the 3D coronal reconstructions. This is a sagittal gray view. This is the endometrial lining until we came here and we have this lesion. So this woman was a 39-year-old and she has a single focal region of adenomyosis where the white arrow is. This is the part in the anterior fundus. Note how the fundal endometrium is obscured by the adenomyosis. We cannot, here the endometrial stopped here. We cannot comment on the endometrial in this part because it was obscured by the focal adenomyosis. This is the black arrow where there is a clear endometrium. Until this point, it was obscured by this lesion. This is an adenomyotic uterus. This is the picture when we do a coronal 3D reconstructed image in the same patient. We found two areas of focal adenomyosis, and there is an adjacent normal myometrium that's in the plane of the sagittal ultrasound image. So again, this is a sagittal transvaginal ultrasound for a 44-year-old woman. It shows subtle echogenic striations. These subtle striations, these are the arrowheads. This represents the subtle striations in this ectopic endometrial glands. That's very small myometrial cysts are seen here. This is the coronal 3D. We could see better visualization of the striations and the adenomyotic features rather than just seeing it by the 2D ultrasound. So we have a beautiful modality as well. If we don't have the facility for a 3D ultrasound, we have the saline infusion sonography. And it's used to evaluate the endometrial abnormalities. We all use it when we have a polyp, when we have a submucous myoma. Also, we do have a hysteroscopy right now, but still sometimes in the lower settings, we don't have hysteroscopy. So we could use saline infusion sonography. I'm going to show you some pictures. They are beautiful in demonstrating lesions inside the myometrial, the endometrial cavity. It's not a primary diagnostic tool for adenomyosis though. The installation of saline allows for the visualization of the endometrium when it's otherwise obscured by the adenomyosis. In addition, it can help to confirm the presence of adenomyosis by directly filling the endometrial glands in continuity with the cavity, as I will show you in these upcoming pictures. So this is the 2D ultrasound picture of a globularly enlarged uterus, that there is a diffuse heterogeneous myometrium as well that could be seen on 2D ultrasound in the anterior fundus. This is when we infuse the saline. This is the saline in the cavity. It distends the endometrial cavity, and you could see these small connecting channels between the endometrium and the myometrium. It's very cool. Although it's a saline infusion sonography, as I mentioned, it's not the primary tool to diagnose adenomyosis, but if you are desperate and you don't have any other clue, you could use it. It might give you a better picture and give you a better idea about what's going on. This is another sagittal pre-injection grayscale. We just did a grayscale ultrasound on a different patient. This patient complains of abnormal uterine bleeding. It shows diffused heterogeneity of the myometrium. You could see that the myometrium sometimes black, sometimes whitish, sometimes cystic, sometimes. So this is the heterogeneity of the myometrium and the obscuration of the fundal endometrium. This is when we distend with the saline infusion sonography. It gives us a linear echogenic buds, and it will represent tracts within connecting between the endometrium and the myometrium after the it looks like the hysteroscopic appearance, but definitely it's less than the hysteroscopy, but still it's useful to add more information to your image if you don't have the facility to do the proper techniques. This is another sagittal pre-injection. This is before we infuse the saline. This is the picture, not really clear. The patient was 48-year-old. She's premenopausal woman. When we do ultrasound, it shows diffuse adenomyosis, as you see here, with cystic lesions that completely obscures the endometrium. In this picture, you can't tell where is the endometrium. It's like a mass. It's like all through. You cannot tell where is the endometrium, myometrium. Then we do the saline infusion sonography, and we could delineate the image much better than the previous one. This is coming through this point after talking about, I showed you a gallery of pictures for the adenomyosis. There are mimics of adenomyosis, and what I mean by mimics, similarities to adenomyosis, but it's not adenomyosis. Other conditions that causes something like the adenomyosis, but it's not actually adenomyosis. So if you see this lesion in this patient, you cannot delineate the endometrium, and you are seeing here cystic structure and multiple cystic structure, you need to take a careful history from the patient, what medication she is taking. This was a picture of a patient that she was taking tamoxifen. Tamoxifen is a selective estrogen receptor modulator. It acts as an antagonist on the breast, and it has some agonistic activity on the uterus. So it causes sometimes endometrial hyperplasia, cystic hyperplasia, and some changes within the uterus. So this is the ultrasound appearance of the adenomyosis when the patient uses tamoxifen. You need to bear this in mind, taking a proper history, making sure that it's not related to the tamoxifen. And by the way, when we stop the tamoxifen for those patients, these endometrial changes go away. The same, it happens in, I have a clinical experience with one of the medications called ulipristal acetate. In 2012, the FDA approved this medication for the medical management of fibroid, and we used to have a picture similar to the tamoxifen changes on the uterus of this medication because, again, the ulipristal acetate is a selective progesterone receptor modulator that acts, it has some agonistic activity on the endometrium, and you need to assess those patients. So before rushing and telling the patient that you do have a problem with adenomyosis or you do have an endometrial hyperplasia or so, please take a proper history before you jump to the imaging, because imaging would be nothing without the proper history from the patient. So again, another mimic of the adenomyosis is the endometrial ablation. And I know that here in Egypt and in the Middle East, it's not quite common for endometrial ablation, but in Europe and in North America, it's a quite common procedure. In the UK as well, you know, it's a very, very common procedure there. So there will be a picture of adenomyosis, looks like an adenomyosis on the endometrial ablation. And this is a delayed complication of endometrial ablation, that it's related to the bleeding from the residual or the regenerated endometrial glands. We know that in endometrial ablation, we destroy the basal layer of the endometrium that we don't destroy. Like during the menses, what happens? There is a shedding of the endometrium, and this shedding happens every month without destroying the basal layer. When we want to stop the bleeding or to want the patient not to have a monthly period, and we don't want to go for hysterectomy, sometimes we opt for, or the patient chooses with us, the endometrial ablation. And in these cases, there would be a picture on ultrasound. If you do a scan after endometrial ablation for the patients, you would find the picture looks like adenomyosis, and I'm gonna tell you how to differentiate this clinically. So this is before endometrial ablation. This is a scan we do for the patient. This is a transvaginal ultrasound, and it shows the uterus obscured. Before the endometrial ablation, it shows multiple echogenic nodules and the striations. We could see the cystic lesions here and the striations here. In the fundus, this is typical of adenomyosis. So if before endometrial ablation, I do a transvaginal ultrasound, I find this picture, I know that this patient, she has an adenomyosis. And maybe this is a cause of the abnormal uterine bleedings that she has. We did the endometrial ablation to destroy the basalis layer. And this is the picture after the endometrial ablation. We're gonna see this up 3 years after the ablation. This picture was taken. There is a pronounced shadowing, and there is an increased number of the echogenic nodules, as we could see here in the arrows. And the white arrows, arrowhead, this one, it shows here the other one with the hematometra, the black arrow shows the hematometra. This blackish part inside the cavity is a hematometra. This is an blood accumulated inside the cavity. It represents some residual endometrium as a cause of worsening adenomyosis. Another condition, it's very, very important, and sometimes the differentiation is a bit challenging between deeply infiltrating endometriosis and focal adenomyosis. In deeply infiltrating endometriosis, we define it as extension of the ectopic endometrial glands more than 5 millimeters beneath the peritoneal surface. And if you want to know this, we know that the laparoscopy is a diagnostic tool to diagnose the endometriosis. So if it penetrates more than 5 millimeters beyond the peritoneal surface, usually it involves the vesicuuterine or the rectouterine pouch, and frequently is associated with severe pelvic pain, as we know as the presentation of deeply infiltrating endometriosis. So the nodules and the resultant fibrosis from the deeply infiltrating endometriosis can attach to and invade the uterosacral ligament, another very common site, we all know that, anterior rectosigmoid colon, the urinary bladder, or the round ligaments. When the uterine serosa is involved, the ectopic endometrial tissue may invade the myometrium in an outside-in manner. Do you remember when I told you that adenomyosis grows from inside to outside? This is the deeply infiltrating endometriosis grows from an outside to an inside manner. And this is a key. So the ultrasound appearance will be the same as the classic inside-out adenomyosis, as I mentioned, with heterogeneity, small echogenic nodules, echogenic striations, and myometrial cysts, but with a normal endometrial-myometrial interface and without thickening of the inner myometrium. So it has two criteria removed from the definition. First off, it grows from outside to inside. Second off, it has a normal endometrial-myometrial interface. Third off, it doesn't have any thickening of the inner myometrium, which differentiated from the adenomyosis. So careful scanning of the serosal surface of the uterus usually shows direct continuity with a hypoechoic deep endometrial implant. And Siegelman and Oliver have described this process as solid invasive endometriosis, or what we call it DIE, deeply infiltrating endometriosis of the posterior uterus. They consider it a mimic. A mimic, it means resemble. Looks like an adenomyosis, but it's not an adenomyosis. So the deeply infiltrating endometriosis, this is a 36-year-old woman. You know, this two kissing ovaries with endometriomas beside on the posterior aspect of the uterus. This is typical of kissing ovaries seen with deeply infiltrating endometriosis. This is another picture where we have a sagittal grayscale. It shows echogenic nodularity and small cysts in the posterior, small cysts here, you could see it in the posterior myometrium, but you could see here, the cysts are coming from outside the uterus to the inside. It's not like the adenomyosis coming from inside to the outside. It obscures the posterior aspect of the uterus and it represents deeply infiltrating endometriosis. So this is not an adenomyosis, it's a deeply infiltrating endometriosis. So this is a Sunny clip for the same patient with a better view. As I mentioned before, it will give you a better understanding of the outside in adenomyosis versus the outside in endometriosis versus the inside in adenomyosis. Let's watch this together. This is a Sunny clip. You could see here in the posterior aspect of the uterus. This is a deeply infiltrating endometriosis. It's not an adenomyosis. It doesn't qualify to be an adenomyosis. Now we have a very important differentiation as well between the adenomyosis and the fibroid or the Lyme myoma. So when we have patients with Lyme myoma and adenomyosis, they frequently present with similar symptoms. So clinically wise, we cannot really differentiate because they're gonna present with uterine enlargement, they're gonna come with heavy menstrual bleeding, with painful periods, with anemia, so we cannot differentiate on the clinical grounds. When we do ultrasound, it can be very similar as well. So particularly in cases of focal adenomyosis, really, it needs an expert in ultrasound with a proper training, working for years in a very good tertiary center in order to differentiate between the focal adenomyosis and fibroid. Sometimes it's really challenging to differentiate. So the accurate differentiation between the two entities is important because the most effective treatments for the Lyme myoma and the adenomyosis will differ. As I just mentioned before, that we could treat fibroids differently. Sometimes we could use medical management, we do only myomectomy, we don't do hysterectomy. So the diagnosis is important because the management is different. Because the Lyme myoma has a pseudocapsule, as I showed you before on this color Doppler image and the 2D image, it manifests as a discrete, well-marginated mass, often with a hyperechoic swirled appearance, like Morley appearance, like the onion. While focal adenomyoma, it has ill-defined borders. It's often helpful feature characteristic of the Lyme myoma is the presence of calcification and the focal bulges in the uterine contour. I'm going to show you here a very important table. This table will help you to differentiate between the adenomyosis and the Lyme myoma. You're going to comment on the borders. In adenomyosis, it's indistinct borders. Sometimes you cannot see any distinct borders for the adeno, but in leiomyoma, you would see distinct, usually round border, giving rise to the capsule. The shadowing in adenomyosis, it's thin, parallel, vertical, Venetian blind shadows. As I told you, from Venice in Italy, they use these shutter windows. It looks like those shutter windows. You could draw it with a pencil. But in leiomyoma, it's edge shadowing. It's dense shadows from the calcification. It thick shadow, dense shadow. It's not pencil-like as in adenomyosis. The echo picture, you're gonna find fine heterogeneity within the adenomyosis, sometimes with nodules, as I showed you, with striations, but in leiomyoma it would be very variable and it's often swirled. Swirled means like the onion in rings. The echogenicity would be mildly increased in adenomyosis, but usually would be hypoechoic, but sometimes it's variable. You cannot depend on echogenicity much because sometimes it's very variable in leiomyoma. No calcification in adenomyosis, no calcification. It's usually hyperechoic and calcified, and it's common to find the calcification. It will be chunky calcification with the leiomyoma. The cysts, we find tiny cysts, very, very small tiny cysts, as I showed you. Cystic striations, as I showed you many pictures of the adenomyosis, but with leiomyoma, usually it would be solid cyst and it have macrocystic degeneration. We know that fibroids degenerate. Vascularity, when you put the color Doppler flow, it's increased. There are penetrating vessels, but in the fibroids, it's qualitatively variable, typically circumferential around vessels coming from around the myoma. The endometrium would be normal thickness in distinct borders because the myometrial interface is disrupted, but in the leiomyoma, it should be a normal thickness and borders that may be obscured or distorted in some of the leiomyomas. The location for adeno would be central, contiguous, or which within the endometrium, but the leiomyoma, as you mentioned, the FIGO classification is much better classifying myomas, submucosal, intramural, or subserosal. According to the new FIGO, you could see the different stages of the FIGO classification for the myoma. So I hope this table actually summarizes the differentiation between the leiomyoma and the adenomyosis. When we put the color Doppler ultrasound on, the vessels will be depicted as coursing through areas of adenomyosis, while vessels in the leiomyoma are typically seen around the periphery. That's a very important point to understand the difference between the vascularity of the myoma and the vascularity of the adenomyosis. This is the shutter windows, as I told you, when you hear about the Venetian shutter window border or the blinds, this is the appearance in the adenomyosis. Focal adenomyosis and leiomyomas, as we mentioned, we have transverse and the T2 weighted image on MRI. It shows focal adenomyosis. You could see very clear on the MRI, the focal adenomyosis, which can be easily overlooked at ultrasound. This is the same picture on ultrasound. We didn't detect that. So this was the picture on ultrasound. This was the picture when we used the T2 weighted images. It could be looked on ultrasound to delineate the lesion. Another very important mimic of adenomyosis is a condition called vascular malformations. We all know these vascular malformations, and we have some unlucky colleagues that they went for D&C biopsy, and the patient bleeds horribly, and they find it's an arteriovenous malformation instead of being products of conception, and some of them it was really disastrous. So vascular malformation, they appear as focal areas of heterogeneity in the myometrium with multiple hypoechoic or anechoic spaces, ill-defined margins similar to adenomyosis. However, a vascular abnormality will not disturb the endometrial myometrial interface. That's the key word here, that it won't disturb the endometrial myometrial interface. It's there, but it will not disturb the endometrial myometrial interface. And the most diagnostic feature is the pattern of the flow. When you put the color Doppler ultrasound, you would find that the cystic spaces, they fill with pixels of alternating blue and red. So when you do have this alternating blue and red flow, and the spectral ultrasound Doppler demonstrates the turbulent high velocity flow and the low resistive index, this is indicative of a vascular malformation, not an adenomyosis. This is the appearance of the vascular malformation on the 2D ultrasound. You could see the cystic lesions, but it has nothing to do with the endometrial myometrial interface. This is when we put the ultrasound, the color Doppler flow, we have a high velocity flow. This is typical of the arteriovenous malformation. This is not the vascularity of the adenomyosis. So this is another mimic of adenomyosis, and you need to know that. So in conclusion, Transvaginal ultrasound is now the primary imaging modality for the diagnosis of adenomyosis. Why? Because it's widespread, as I mentioned, it's minimally invasive, or it's non-invasive, I'm sorry, and it's widely available, and all what it needs is the acquisition of the skills that's necessary for the clinician or the operator in order to better identify the adenomyosis and identify the other pathologies during the scan. It also allows for better understanding of the scope of adenomyosis in postmenopausal women of all ages. Transvaginal ultrasound can be used to confidently diagnose adenomyosis in the majority of cases, particularly if multiple ultrasound findings manifest. Specific histologic-based criteria aid in the ultrasound interpretation and include findings related to the ectopic endometrial glands and stroma, as I mentioned, myometrial hyperplasia and myometrial hypertrophy, and increased vascularity. And advanced ultrasound techniques, including obtaining the 2D and 3D coronal reconstructed images and the cine clips, as I showed to you, are very important. And also performing sonography infusions, saline infusion sonography, if you don't have the facility to do the 3D reconstructive images. All of this can be used to corroborate standard ultrasound findings, especially when we do have existing leiomyoma with the adenomyosis. As I mentioned, adenomyosis, sometimes it's a very challenging diagnosis in terms of its association with other similar conditions and with no differentiation from the clinical perspective of the patient or the clinical presentation. These are my contacts if you would like any correspondence in Canada. And thank you so much, Dr. Shadi, for having me tonight. I'm really pleased to be with you.
Many thanks, Dr. Heba, for this very nice presentation.
Thank you.
Are there any questions for Dr. Heba?
Anyways, Dr. Shadi, you have my contacts if you need any response to the audience. If you don't have time now for the questions, you could send it to my email and I would respond to that.
Okay, many thanks, Dr. Heba, for this.
Thank you so much.
Okay.
Thank you.
Dr. Sahar now will talk about ultrasound and gynecological emergency. Dr. Sahar?
Can you see my screen?
No.
No?
Not yet. I need to get out. Okay.
Yes, please.
So I stopped sharing mine. Should be okay now.
Yes.